cases of classic heme path case, and then to show you some molecular study. So the first one is our pretty common acute myeloid leukemia case. So the history is, I just cut really short, so you just notice that the old male, and then the family history of CML and AML. Then this patient has the leukopenia, thrombocytopenia. Then the bone marrow shows 30% of blast, and then the core biopsy also showed 20%, and then flow showed all of these marker, and then we know this diagnosis should be AML, acute myeloid leukemia. Then the question is that what are we going to do for further test for this patient? So I think we all know that, but here is just a really nice table from Dr. Ding's book to summarize what further tests we need to do. The first one is cytogenetic. So we can know all the chromosome abnormality. Here's some example here, what you may find. Then we have gene mutation test. I just highlight these two. Hopefully you will remember at least these two genes from this lecture. The first one is FLT3 ITD. FLT3, we have three major groups, but here the ITD is a really well-known group because related to prognosis or our treatment choice. And then the other one is NPM1. So this one also related to the prognosis. So from this gene mutation test, we will use a fast test because we hopefully will get the result of these two genes within 48 to 72 hours. So here, we mentioned at least in patient eligible for intensive chemotherapy. Then we have read the gene rearrangement based on FISH or multiplex PCR. So we know that PML vera is really important. Transfusion 15-17 of APL, because whenever you're on call, the really important thing is to recognize whether it is APL, and then we can tell the clinical claim in really time sensitive thing. So the cytogenetic analysis and FISH of this patient just show normal male karyotype. Then this patient had normal karyotype. So why we want to do a molecular test? So from the history, we know first we use this FAB classification based on the morphology. So we subdivide AML into M0 to M7 group. But the problem of this classification is that it's not really related to the prognosis or any targeted therapy. So that's the reason we have to do some molecular tests, because we can predict the patient of their prognosis and also choice of treatment, and also we can monitor the disease using minimal residual disease monitoring from this gene mutation-based test. Then here's a old version in 2011 from this molecular pathology in practice book. And then so far, even like 10 years ago, we already know some really familiar gene at that time. If we have NPM1 mutation or this gene CEBP alpha mutation, at that time, we already know the patient had a favorable prognosis. And then unfavorable, that is FLT3 ITD. I know a lot of gene here, but I think in this lecture, if you can remember these three, that would be really good for the blood preparation purpose. Then the go to our more updated one, 2021. And here's a summarize of the adverse risk unfavorable prognosis marker based on cytogenetic abnormality and also molecular abnormality. So here, I already shared this PPT, so you can read it by yourself, or you can also welcome to read Dr. Bing's book. All the information you can find there. So I just highlight again here. Unfavorable prognosis is related to wild type NPM1 and free ITT high allele burden. Then we know every time in a tumor, malignancy disease, if we find mutated TP50, always related to unfavorable prognosis. And then for the good prognosis, we know in APL patient, if the patient has PML vera, we have really good targeted therapy, so the patient will have good prognosis. Then from molecular test, if we find mutated NPM1, but we do not find FLT3 ITT mutation, or if we find this mutation but our allele ratio is less, but from some literature kind of controversial. So I think for the text purpose, remember mutated NPM1 without free ITT mutation, that is a good prognosis. And then this gene again, CEBP8 biallele double mutation also related to better prognosis. So let me talk about free gene. So this gene mutation can be found in approximately 1/3 of all AML patients. And then there are three major groups of FLT3 activation mutation, because this is an oncogene. So if it mutates and then activated, it will activate the signaling pathway for the cell proliferation. Then these are the three major groups. The first one is FLT3-ITD, internal tandem duplication in JM domain. And then around.
What does that mean, ITD? Yes, you just said the word. Like, what kind of mutation is that?
You don't know that, I have next slide.
Okay.
Yeah.
Anybody know? It's a duplication, right? Yeah, so like the third word is duplication. But what does internal tandem mean?
Next to each other,
Uh-huh.
and then they're next.
So it's a duplication of what?
Like the gene.
Yeah, it's a duplication of the FLT3 gene, right? So it's duplicate the gene and then insert it into the gene. So a certain fragment of the gene being duplicated and you see it twice.
So the other one is the tyrosine kinase domain, that's FLT3 TKD. And then the last one, just have less than 2%, not really important. There's a point mutation in JM domain and in extracellular domain. So I want to put a note here. FLT3, we do not use it for diagnosis of AML because it's not really specific. Other than AML, other myeloid neoplasm, we also can find this mutation, and even other lymphoplastic lymphoma like T precursor cell lymphoplastic lymphoma, we may find this mutation. So we just diagnose this first, and then we use this gene for further prediction of the prognosis and then the treatment choice. So here's the diagram of how this signaling pathway work. So normally, free ligand just binding to this domain receptor and then activate this pathway. So if we have this ITD mutation, usually related to exon 14, then we will activate this pathway, or either TKD mutation here. We can also activate this all of this well-known pathway, and then the cell proliferation and cell survival. So thinking the thing to explain ITD, what does that mean? And then more detail is that this is an in-frame insertion in exon 14 and 15. What does that mean in frame insertion? So I have I'm gonna show you what is in frame. This is the in frame. That means we add at least 3, 6, 9, or something like this nucleotide into the gene. So we can see the normal DNA sequence if just like this, and then we have translation to this amino acid. Then if we have in frame insertion, so we add 3 nucleotide or maybe 6 or 9. But here we can see we still keep this amino acid, we just add something new. And then if non-inframed insertion, just like we just add 1 nucleotide, and then we keep this one, but all the amino acid after this insertion, everything just change. So the whole protein will be destroyed. So, and then we know that this is really important for our test because we know we use PCR-based test. So we know this ITD, flip ITD, we just add 3, 6, 9 nucleotide there. So we just based on the size. So though if this size can be rare greatly, like 3 to 400 base pair, most commonly 6 to 30. And then why FLT3 ITD is really important because it's well known to associated with a high leukemic burden and poor prognosis. Then the other one is a TKD, tyrosine kinase domain mutation. This is the point mutation or deletion. Most commonly affected D835 in exon 20. Contrast to FLT3 ITD, this mutation, the prognosis value is not well established. I think because maybe less finding of this mutation in our patient, so we need more data. So here's a diagram for molecular tests based on multiplex PCR reaction, how we detect this 2 mutation in FLT3. So the first one in JM domain, we use primer to proliferate. And then if we have white type, based on our primer, and then we can application, the size of this product is 330 base pair. So based on our knowledge, because this is an in-frame insertion. So if we detect anything larger than 330, we can say we find ITD mutation. So regarding to TKD mutation, this one is a little bit complicated because you can see we have primer here to amplify this PCR product of this TKD. Then we cover this D835 font, and then we have this PCR product, and then we put these 2 red line here because this is the restriction site for this restriction enzyme EcoR1. Why we use this enzyme here? Because in this D835, if no mutation, these enzymes can just show you here. If in the normal sequence, this is the restriction enzyme site. That means if the nucleotide have this GAT, ATC, and then we use this enzyme, we can just cut here. And then this is happening in our non-mutated normal sequence of this gene TKD domain here. So if we have this D835 mutation, like this G just changed to A. So the nucleotide will be AAT, ATC. So that means when we add this enzyme, we could not cut here. So that's the reason when we see the result is like this. If undigested PCR product is 150 base pair. And then we add this enzyme and then try to cut this PCR product. If we can cut, then we will have white type 80 base pair. And then the reason we have another precision enzyme, we design into this reverse primer. That is, we want to use this as a control for our enzyme because, if our enzyme is not working in this PCR product, we will have this undigested band, 150. So if we have a PCR product and add enzyme, if we do not have this EcoR5 in the enzyme here, and then we add the enzyme to just digest, we may see this 150 base pair band, but it's kind of close to this 129 band if we do not have this restriction enzyme site. So it's kind of confused. So we need this control for show us whether this enzyme is working. So just remember in ITD mutation, we just based on the size. We do not do any enzyme cutting. And this TKD, we use enzyme cutting if we get a shorter band, 80 base pair, that is a white type. And then if larger than that is 130. And then we also would like to see whether our enzyme is working in this PCR product. So here's one of the results we can see here. So I just already marked here, this is 330. So if a patient will have this ITD result like this, what do you think of this one? Seems we have two bands. One is larger, one is smaller. And then this is a white type band. And then this number 2 is a ITD mutation. So and then for TKD, also we just based on the size, you can see we do not see 150. That means our enzymes works really well. Not everything just digests by the enzyme, and then we get this less than 100 base pair band. So based on this patient had ITD when a new mutation, then TKD is white type. So it's how we read this picture. Okay, let's go through some event question. So I can give you 30 seconds to just wait. Or anyone, if you have the answer, just shout out. Okay, so let's go through one by one. Cannot be performed because of patent issue in the United States. We all know that is wrong because we have this test. And it's always performed by analysis of restriction enzyme digestion product. Is it correct for this statement? This is the ITD. No, because this is for the TKD. Why we use this restriction enzyme. Then C is commonly performed by measuring the size of the PCR application. That is correct. We just read the size. We do not use any enzyme for this ITD. And for the other two, I already mentioned before, this one is not specific, so not AML with translocation AN21. Then it's usually performed to monitor disease progression. No, we're gonna use that. Just a prognosis marker and then transfer treatment. And next question. This is the NPM1 mutation without FLT3 ITD mutation. I think this one will be easy and fast. And
Better prognosis.
Sorry?
Better prognosis.
Yes, it is a better prognosis than those of FLT3. So for this one, how about choice 3? What kind of diagnosis we are worried about this?
APL.
Yes, it's APL. Do we really use watchful waiting for an AML patient? Definitely not, even the patient had really good prognosis. And then this stem cell transplantation. My understanding, if the patient estimate better prognosis, we usually do not use this method. That's what I thought, because we have really high risks if we use stem cell transplantation. If we have any other therapy like targeted therapy. Okay, there's a last question for this topic. Maybe we could. What kind of mutation of FLT3? Yes, this is an oncogene activating mutation.